Hello, I'm Aleix Prat, medical oncologist from Hospital Clínic here in Barcelona, Spain. Before I begin, I would like to thank Dr. Sharma and Dr. Clem for their kind introduction, and invitation. It is a pleasure and honor to be here today. So in the next 25 minutes, I'm going to review this important topic, which is how biomarkers are informing and potentially will inform us about treatment decisions, what progress have we made, however, also what are the pitfalls and the things that we should consider. It's going to be a talk mostly conceptual, but I hope we can have a nice discussion about it. These are my disclosures. I would like to point out that I will briefly touch base on a particular biomarker, which is HER2-DX, which has been licensed to reveal genomics. So there's no doubt that we're using already biomarkers in the clinical setting, no doubt about that. And today we're classifying breast cancer using, I would say, 3 biomarkers that are currently being performed, which are, as you know well, estrogen receptor, progesterone receptor, and HER2. One thing to point out about it, and I think we should not forget, is that these biomarkers were designed specifically in pivotal clinical trials that led to, on one hand, show the activity of anti-HER2 treatment in HER2-positive disease and endocrine therapy in ER-positive, PR-positive disease. These biomarkers were designed with specific assays and, in particular, specific cut points that determined this objective, which was to select patients who benefited from anti-HER2 therapy on one hand and endocrine therapy on the other hand. So these 3 biomarkers were not designed specifically to describe biology. This was a secondary, I think, objective. So we need to keep in mind where the biomarkers were developed and for what particular reason. In fact, when we look at biological classifications that look at this biology underlying these 3 different groups, the ER-positive HER2 negatives, the HER2 positives, and the triple negative, we realize that there is much more biological heterogeneity within each group. And no doubt, we can see all the subtypes represented across the 3 immunohistochemistry-based subtypes. So this tells us that biological-based classifications are different from classifications designed specifically with 3 biomarkers that determine the benefit to specific drugs. Another, I think, thing to point out is that we do have, for biomarkers, scales that talk about the ability of one of these biomarkers to predict treatment benefit. This, for example, is one example, the ESCAT ESMO scale for clinical actionability of molecular targets, called ESCAT classification, but there are others. Level 1 evidence, what will be ready for prime time, ready for clinical use today, is when alteration drug match is associated with improved outcomes, and this is shown in a prospective clinical trials. We call it investigational when this match within the alteration, the biomarker and the drug, is associated with anti-tumor activity, but the magnitude of benefit is still unknown. And then we have other categories like hypothetical target or combination development that are basically a proof of concept studies. So we do have this classification. And what we can say today, unfortunately, is that after more than 2 decades of a lot of translational science in breast cancer and also other cancer types, but today we're talking about breast cancer, today we don't have that many biomarkers being used in the clinic. Apart from estrogen receptor, progesterone receptor, HER2, we now have 3 additional ones: germline, BRCA1, BRCA2, PD-L1, and PIK3CA somatic mutations. Of course, there are promising biomarkers under investigation for breast cancer listed on the right. HER2 low category is 1, the levels of TROP2, HER3, germline PALB2 alterations, and also what we call the HRD alterations, intrinsic subtypes as well, and potentially CtDNA as a tool or a biomarker that could help guide treatment decisions. These are under investigation at this point. Also, we'd like to point out that you can see here, most of the time we're talking about single biomarkers being incorporated each time. And the question is how we integrate this in a scenario where we have different biomarkers, different biology, and that potentially a single biomarker does not explain the full story. And I'll touch base about this concept later on. But before, I think it's important when we talk about biomarkers and biological classifications, we need to take into account what we're talking about. Are we talking about, for example, cell surface proteins, which are definitely of importance in oncology and in particular in breast cancer? Are we talking about an oncogene in particular? Are we talking actually about the phenotype of a cell, of a tumor cell, for example? Or are we talking about the tumor microenvironment and targeting that with specific drugs? I think understanding better when we look at biomarker, whether it is one thing or the other, or potentially a combination of two, might also help us better understand what is going on in the tumor and potentially better understand how to treat and also how to combine these new treatments with other drugs. One particular aspect is cell surface antigens. There's no doubt that with incorporation of potent antibody drug conjugates against several of these antigens in the surface, things are changing a lot. And what's interesting is that probably for these particular biomarkers, we don't really need to understand much what is the underlying biology of that particular receptor that we're targeting. HER2 as an example, or TROP2, or anti-HER3. We use those as a way to guide an antibody and to deliver potent chemotherapy. So I think this is interesting because we're seeing that potentially these ADCs might bring another layer of complexity about biomarker development, because potentially the underlying biology of that tumor cell doesn't matter that much. It's just about finding the right antigen on a tumor, and specifically an antigen that is not present in normal tissue. This is one publication that we reported last year in ESMO Open. It was an in silico exercise to identify potential cell surface antigens in breast cancer in general and according to intrinsic subtypes. And we did by looking at different libraries out there of normal tissue as well as tumor tissue. And we came up with a list of hundreds of potential targets. So definitely these are biomarkers that have a lot of potential because are quite unique of specific subtypes and could be treated again with new ADCs. HER2, I think, is a perfect example of this concept, especially for ADCs. HER2 has been seen as an oncogene, and when I studied, and they were explaining to me what HER2 was, the first word that came out was, this is an oncogene. I think now we are realizing that this is not always the case. No doubt there is a gradient of expression of this protein from 0 for non-bioimmunohistochemistry to 3+. But again, there is a gradient. And at the same time, we know that not because it's high expressed, that doesn't mean that the receptor is activated. And this is the thing, that disconnect between having a lot of receptor and this receptor being activated. In fact, we have now seen across many studies, and again, I'm not going to show you all the data, this is very conceptual, but we've seen that even in the category of 3+, where we see under the microscope a lot of protein, a lot of HER2, not always this HER2 is signaling. And actually, by using more sophisticated methods, such as mRNA expression and others, or phosphoproteins, for example, we can see that there is a subgroup of these 3+ cases that definitely HER2 is highly activated. These tumors are HER2-driven. And this is what we call the HER2 as an oncogene. But many of the times, this HER2 is on the membrane, but is not truly signaling downstream. So definitely, in that scenario, HER2 is not behaving as an oncogene. It's more behaving as a surface receptor by itself. So again, trying to understand whether we're talking about cell surface by itself, cell surface together with an oncogene addiction, or just oncogene addiction. I think these are the things, the topics that we need also to dissect when we talk about a biomarker. Interestingly, we have the HER2-low category, which is right in the middle. And thanks to potent ADCs, we're seeing that there is activity of these drugs against HER2 in these HER2-low cases. The question in this scenario was, what are these HER2-low cases as defined by immunohistochemistry, by intermediate immunohistochemistry-based expression? Here are two articles, one led by our group, trying to characterize molecularly this group of patients and tumors. And what we've seen, I think, is something that is very clear, is that these HER2-low tumors in general are not HER2 addicted. They have low HER2 signaling. So there is some protein on the membrane, but this protein does not seem to be activated. You can see here on the left, you see HER2 1+ category, more than 700 cases. On the right, the 2+ category, each negative. Very similar distribution. The vast majority of these tumors are luminal A or luminal B. Just a few are HER2 enriched, and many, 10% approximately, are basal-like. So definitely this group is mostly has low HER2 signaling. So potentially this group is where potent ADCs might work, but potentially other strategies that target HER2, such as, for example, inhibition of the kinase, of the activation, might not yield good results because, again, the receptor is not activated. Moving from cell surface proteins together with some activity in oncogenes, at the same time, it'd be great to identify simple oncogenes. For example, like what has happened in other cancer types like melanoma, BRAF mutations, lung cancer, for example. In breast cancer, we are not identifying that many oncogenes. PIK3CA somatic mutations could be seen as an oncogene, and we have a few other potential candidates that are on one hand rare, for example, NTRK fusions, which are very rare in breast cancer, but if they are there, potentially drugs like entrectinib might be highly active. Others are looking promising, AKT1 mutations, potentially MYC amplification, cyclin E1. These are potentially drivers of the disease, and potentially we can target those with drugs. But again, in breast cancer in general, we are not identifying that many oncogenes beyond the HER2 in a subset of cases and beyond PIK3CA somatic mutations and NTRK fusion cases, which are, again, very rare. So moving from that, I do think that in breast cancer, we need to start thinking about other types of biological classification that might inform us about how to treat patients. And one of these is phenotypes. I think we're having examples how identification of specific tumor phenotypes, it can allow us to predict the benefit to specific drugs. For example, HRD, which is a reflection of DNA repair deficiency, especially BRCA1, BRCA2, but potentially other DNA repairs, is actually a phenotype. We are not targeting with PARP inhibitors BRCA1 or BRCA2. We're targeting the pathway that is activated in this scenario of DNA repair deficiency. Similarly, TMB, tumor mutational burden, is a reflection of something that is going on at the DNA level, a lot of mutations that lead to new neoantigens, that lead to immune infiltration, immune activation, and potentially anti-PD-1, anti-PD-L1 drugs might be active in this particular scenario. So again, TMB is a biomarker that identifies a phenotype. Microsatellite instability high, similarly to TMB, also identifies a particular phenotype at the DNA level that predicts immunotherapy benefit. And I would argue that also RNA-based signatures, which are profiles, are identifying also activity and profiling and phenotyping, such as intrinsic subtype, might also help us better predict treatment outcomes. As you might know, last year we reported in this regard across the MONALEESA-2, MONALEESA-3, MONALEESA-7 program, more than 1,100 patients treated in these phase 3 clinical trials, patients with hormone receptor positive, HER2 negative, treated with endocrine therapy, with CDK4/6 inhibitor, ribociclib, or no CDK4/6 inhibitor. And what we showed is that intrinsic subtype identification of phenotypes within ER positive, HER2 negative is prognostic very clearly. If you're luminal A, you do better than luminal Bs, and you do better than non-luminals. And in the presence of ribociclib, we did see that luminal A, luminal B, and HER2 enriched, the pink line, improve their outcomes from a PFS perspective, whereas the basal-likes identified by gene expression analysis, by intrinsic subtyping, do not benefit from endocrine therapy and CDK4/6 inhibition, and despite this group having very poor outcome. So I do believe here we have a phenotype identified within ER positive, HER2 negative. Is a phenotype that represents 3% of all ER positive, HER2 negative that don't seem to benefit from this group. And actually the interaction test was significant. Lisa Carey presented at San Antonio, last San Antonio, updated data now looking at overall survival across this program, again showing that subtype is prognostic, and again that the basal-likes don't benefit from an OS perspective to these treatment strategies. So potentially here we have a predictive biomarker, which is the basal-like biology, that could help us identify patients that probably first strategy is not endocrine therapy plus a CDK4/6 inhibitor. Of course, we need to find what is the best strategy, and we can discuss this later. At the same time, I think we're seeing that single biomarkers are probably not enough. We need to combine them. At the same time, there is a revolution in new technologies that are arriving at the same time, and this is allowing us, I think, to develop new ways to measure these biomarkers. On one hand, liquid biopsy is a perfect example, that in breast cancer, it might be less useful for identification of oncogenes, because clearly oncogenes are generally rare beyond PIK3CA somatic mutations. Also, new means to measure imaging and imaging-based biomarkers, for example, are promising. Also, new ways of measuring biomarkers, such as immunohistochemistry or protein-based. I think we need methods that are standardized, and this is also one of my messages of my presentation. We need good quality biomarkers. In 2021, we cannot rely on biomarkers that are inconsistent, that are not reproducible. I do think we need to ask, as we ask for drugs, for the best quality possible. No doubt that NGS is changing everything, and there's no point of sequencing one gene when we can sequence a certain amount of genes, hundreds, for the price of one. But at the same time, there is complexity there from an analytical perspective that we need to consider. But at the same time, sequencing more also allows us to identify phenotypes at the DNA level that might be of interest in the future, such as HRD, for example. This is just an example of how, by looking under the microscope, one can identify the classical three groups of HER2 expression: HER2 negative, HER2 zero, HER2 low, and HER2 positive. But by more sophisticated technologies, such as mRNA, and here using the nCounter, the nanostring platform, you can see that by looking at almost 400 samples across all the range of expression by protein, by immunohistochemistry, you see that we can see a wide range of expression, that from the highest expressor to the lowest expressor, we're talking about a difference of 8-fold difference. So by more sophisticated technologies, we can discriminate much better the dynamic range, the expression of this receptor, and this potentially could be of value for predicting benefit to anti-HER2 based therapy, for example. And the similar thing could be done with other biomarkers. No doubt that liquid biopsy is here to stay and will allow us not only to identify somatic mutations, but also by looking at the quantity of CtDNA in plasma in early disease and potentially even more in advanced disease, one can monitor disease and identify early responders at 2-3 weeks of starting therapy. Early responders, as shown by Nick Turner, showing that by treating with endocrine therapy and palbociclib, early declines of CtDNA are a good sign of good prognosis. And I think this tool should allow us to design the next generation of clinical trials, where probably instead of waiting until progression of disease radiologically or clinically, waiting until a situation where the tumor has grown in heterogeneity, intertumor heterogeneity, the tumor is more difficult to treat upon progression, maybe they deliver strategies to treat these tumors before this radiological progression exists, when CtDNA already detects that that tumor is not benefiting much from a treatment strategies. This new concept of advancing a therapy when CtDNA reveals that this tumor is not responding, I think are the new type of studies that we should be doing. Challenging as well, but we should be doing. And this brings me to another point, which is trying to integrate many of these data types. I think in the last 20 years, we've learned a lot about the different biomarkers that predict prognosis or treatment response by itself. But at the same time, I think we're learning that this is not about a single biomarker. It's about combination of biomarkers, combination of different data types that at the end of the day help us better predict, better identify biologically homogeneous tumors that most likely behave similarly we can treat with particular treatment strategies. I think we are in the era of trying to combine these biomarkers. And of course, by doing this combination of biomarkers, we're not going to answer all questions, but if we design the proper studies, we might be able to answer particular clinical endpoints of relevance. And I think this is something that we should consider. And here is an example that, of course, I'm biased about this because it's our own work, but I think it illustrates what I just said. This is an example of a design of a biomarker, HER2-DX, which integrates clinical data, which is most of the time very important, together with genomic data. And in this first exercise, we also combine tumor infiltrating lymphocyte data. Altogether, 17 variables, and we not only combine all these variables, but we train these variables to predict, in this case, prognosis in early stage HER2-positive breast cancer. Interestingly, in this publication in Lancet Oncology, we observed that when we evaluated this biomarker as a predictive biomarker for predicting pathological complete response, we observed that it did not predict pathological complete response, whereas it did predict prognosis because it was trained to predict prognosis. But the fact that when you train something for one particular purpose, it does not for other purpose, I think this is something that we need to think about, because this is the reality. We should not expect a biomarker to predict everything or different things. If it was designed for one thing, it's meant to be used for that particular thing. So very recently, we have now updated the HER2-Dx now with an assay that is just genomics together with clinical data. We have removed TILs using immune gene expression. The first reason is that TILs are not reproducible, and I don't think we want biomarkers that are not reproducible. We need, as I said, the highest standard. We should ask the highest standard of analytical validation for a biomarker. This is a 27 gene assay that integrates immune infiltration, luminal differentiation, tumor cell proliferation, expression of HER2 amplicon, including RBB2, tumor size, and nodal status. And the assay integrates all these data types and provides, on one hand, prognosis, and also we train the same variables, but now to predict pathological complete response. And here you can see the association of the 6 variables with each clinical endpoint. And the relationship between the variables and the endpoint might be different. For example, more immune infiltration, more blue, better outcome, and more probability of PCR. Luminal, for example, expression is associated with blue, better outcome, however, less probability of PCR. Proliferation, exactly the opposite. More proliferation, worse outcome, but better probability of PCR. And tumor burden, as usual, poorer outcome and less probability of PCR. So the two scores are unrelated. The correlation coefficient, as you can see here, is minus 0.19. And again, with the same variables, but trained to predict different endpoints, they don't have to be related, as I said previously. And I think it's the type of exercises they should be doing with other contexts. And actually, in this regard, there is data supporting this disconnect between predicting PCR and predicting prognosis. This is data from the CLGB 406-1. They did a huge effort, Arantxa Fernandez and Chuck Peru and Lisa Carey. They evaluated more than 680 RNA-based biomarkers, and they evaluated whether they are associated with PCR or if they are associated with relapse-free survival in early-stage HER2-positive disease. And they observed that 30% of biomarkers are associated with PCR status, but only 7% with relapse-free survival. And only 3% of them, 22, are associated with both PCR and relapse-free survival. So as you can see, different objectives. And as you can see, it's easier to predict PCR than relapse-free survival. Similarly, and very recently published in JCO, the similar exercise, but now in the CLGB 406-3, in triple-negative early-stage disease, showing very similarly the same thing, that among more than 680 RNA-based biomarkers, 20% are associated with PCR, only 10% with event-free survival in this context of early-stage triple-negative disease treated with chemo, and only 5% with both. So again, it's easier to predict PCR than event-free survival, and they are predictors that predict one thing, but do not predict the other, and the opposite. So I think these are the things that we need to also start thinking about. So to finish, no doubt that we should be optimistic, but at the same time, many challenges to implement new biomarkers lie ahead. And here, let me point out a few. Let's be realistic, first of all. 20 years of translational research and a few biomarkers being implemented. The bar, in my opinion, to implement biomarkers is very high. This is fine. For example, as I said, ESCAT 1 means that you need to run a prospective trial with a primary objective that uses the biomarker and its ability to predict a treatment response. So not many reach that level of evidence. Standardization is key for biomarker implementation. In 2021, as I said a couple of times in this talk, we should not be using biomarkers that are not reproducible. And I think here drug agencies and regulators should mandate this. We also need to take into account that some of these biomarkers are not black or white. They run as a continuous variables, and this also poses a challenges because you need cutoffs to make treatment decisions in the clinic. So these cut points are not easy to establish. You need to design proper studies to do that. Regulatory agencies, I think regulators are key as they regulate drug access and drug indications. They should also regulate diagnostics. If not, I think it's going to be very difficult to introduce more and more biomarkers. No doubt that DNA is important, but at the same time, I think in breast cancer, DNA is not enough. We need biomarkers at the RNA and protein levels, and most likely, this is what we should be doing in the next years. And finally, my last message is that we need to combine these biomarkers at some point, because probably this is going to allow us to better predict treatment response and prognosis. Thank you very much.